I'm Renuka Bhat. I'm the clinical leader in fetal medicine, which is also known as August in counties Manukau, DHB, and I'm based in Middlemore Hospital. And I will take on from screening regarding a new test that's likely to come up soon called NIPT. Just a little bit more information about it. And the reason is that National Screening Unit is likely to bring it in to test or rather screen for Down syndrome. It is a very sensitive test. So NIPT is what I will use, but as you have heard, prenatal screening has been around for a long, long time. And this test checks DNA in maternal blood. It analyzes fetal cells, cell-free DNA, and these are the various names, non-invasive prenatal screening, cell-free DNA, etc., and they're all interchangeable. So mother's blood has both maternal and fetal DNA. The maternal DNA comes from the hematopoietic cells that are disintegrating and other cells, and the fetal DNA is coming from placental fragments. Now, placenta has the same genetic composition as the fetus, and this can be seen as early as 4 weeks in the pregnancy and increases at the rate of about 1.1% per week up to 21 weeks and 1% per week afterwards, and is in a ratio of 20% of fetal to 80% maternal DNA. It is cleared within hours of birth, so it has been tested 2 hours after delivery and was not found, no fetal DNA was found in maternal plasma. And so it tells us that this plasma or this DNA is related to the current pregnancy, not to any past pregnancies. Cells have been evaluated in the 70s in the past, fetal cells in maternal circulation, but they were all present, but they could have been present for a long time because they apparently, you can't make out whether they are from current pregnancy or previous pregnancy. The size of the fetal DNA is also smaller than the maternal DNA, and in some of the tests that have been on offer, that has been used to differentiate between the two. I'll skip this because I think I'll go over time, but if you want to ask me about how it's done, I am happy to talk about it. So what does it test for? It tests for Down syndrome mainly, and trisomy 18, 13, and monosomy. But this method of analyzing fetal DNA is also used for rhesus typing. So if in a rhesus-sensitized mother, if we want to know about fetal and a heterozygous father for D antigen, we can test the fetal DNA for the blood group of the baby and advise the mother accordingly. It's also used for this purpose. It is not used so much in New Zealand because we have to send the test out, but is used in the UK also for single gene disorders and other inherited conditions. So looking at how accurate it is, if you look at the first trimester screening that we offer here, the combined screening with nuchal translucency, HCG, and PAP-A, has an 80% detection rate with a 5% false positive rate. But in New Zealand, this has been audited to be about 78%. So a lot of cases are missed. Cell-free DNA screening has a 99% sensitivity in most studies, but at its worst has a 96% detection rate with a 0.1 to 0.5%, depending on what studies you read, false positive rate. So it is very accurate, especially for Down syndrome. Again, looking at high-risk versus low-risk pregnancies, studies have, in the past, it used to be thought that it was sensitive for high-risk pregnancies, but lately studies have shown that it is similarly sensitive for low-risk pregnancies for detecting Down syndrome. If you look at individual components, so integrated test is the most accurate conventional test we have at the moment and combines MSS1, MSS2, and nuchal translucency. And if you look at the bars, you find that cell-free DNA testing is, has a better detection rate for all the trisomies, that is 21, 18, 13, and monosomy X. It is not good for triploidy because in triploidy, The placenta is often small. The amount of DNA you find is also less in maternal circulation, and the test can have a false result. You've heard about current screening for Down syndrome and all the information that goes into it. What results can we get from NIPT? I've written positive, but it should actually read high risk and low risk. So high risk will show that it is very likely that the baby will have Down syndrome, but nothing further can be done unless an invasive test is offered to confirm. A negative or a low risk one is highly likely that it is unaffected, and the specificity again is approaching 100% or is 99%. In about 4%, you might get a result or saying no call or inconclusive. It's because the proportion of DNA in the maternal blood may not be enough to test. It has to be at least 5% or about 4%, at least 5% before testing can be accurate. And this may need to be repeated because, as you remember, I said the amount of DNA that is found in maternal plasma goes up as time goes on. And if you repeat the test a week or two later, you're likely to get a result. So why is it not 100% accurate? And the reason that it's not 100% accurate makes it a screening test and not a diagnostic test, because you don't get a yes or no answer. You can have false positive and false negatives. If you do it too early, again, I've talked about that. Sometimes pregnancies start as DCDA twins with early demise of a twin that might have an abnormal chromosome. So the chorion or the placenta of that twin keeps shedding that abnormal chromosome into the maternal circulation for up to 6 weeks. And if you do the test around that time, you might get a false positive. There are situations where a placenta might have different cell lines that are only confined to the placenta, not in the baby, and that might give a false result. Sometimes also the mother might have an abnormal chromosome which she doesn't know about and is actually tested to be positive in fetal blood, and you think that it's the fetus that's affected. Now, in all these situations, the mother would have an invasive test, and the story would come to light. Now, for false negative, again, if the proportion is too low, the test will not be accurate. And high BMI is also important because this makes the test less sensitive. Sometimes the baby is abnormal and the placenta is normal, and although they have the same genetic composition, if there is mosaicism in the baby, 2 different cell lines, then that might not become apparent, and sometimes there might be technical issues. It is very clear now that NIPT is a better screening tool for Down syndrome. It has a very high specificity and a very high sensitivity. But combined screening, as you heard, gives us other information as well. The question now is, how should this be used and when should this be used? What is the cost and what happens if no scanning is available? So one option would be to use it as a in replacement for the invasive test, and it is being used in some situations for that, and then only proceeding to doing an invasive test if the result comes back high risk. Or we could offer it to women instead of MSS1, and they just have a scan and NIPT. What would be the story there? Or we could offer it as a contingent test. Now, this is not, I'm not proposing that this is what National Screening Unit intend to do. I'm not sure what they do intend to do. This is just what has been proposed in various international meetings as one of the possibilities. So one idea would be to, if it was a high-risk result on a combined screen, like 1 in 50, then to offer invasive testing, because the chance of that coming back positive is high. If it was a low-risk result, and you could say 1 in 2,000 or 1 in 1,000, depending on what we wish to make a cutoff, we would reassure the mother and say the risk from the combined test is low, nothing further needs to be done. And there is a big intermediate group which may be offered NIPT, because this is the group which are often missed on combined screening. There are situations where combined screening might not be available and NIPT might be an option, but we would need to know that the pregnancy is viable and that the placenta is working. So if we offered everyone first trimester screening only, it is cost effective, it screens for other things, but higher invasive testing. NIPT for all would be very expensive and it would miss atypical abnormalities. It does not pick up anything other than Down syndrome and the 3 other. And contingent screening would be useful. It would reduce by 80% the chance of invasive testing. So cost, it does add to the cost. We've talked about this. There are ethical and social issues. It is very easy to, it could be very easy to access if it was routinely applied, and women might not know what they're going in for, just as often women don't know they've had an HIV test or a combined screen and what it means and so on. So there are counseling issues and other issues. Women can use it for non-medical purposes. In Asian countries, women might use it to find out if they're having a boy or a girl, and we know that there is selective feticide happening. And counseling is important. They do need pre-test and post-test counseling. So at the moment, what's happening in Auckland, women front up to a private obstetric clinic and they ask for this test. And they ask for it because they know about it and it's also easy to access, and it's simple, it's just a blood test and they're avoiding an invasive test. The doctors that counsel about it are also happy to discuss it because it it ensures that they know that the baby is normal, doesn't have Down syndrome. So these are the tests that are offered. Lab Tests offers it for $675, and Harmony is the name of the test. Now in Escort, you can get counseling, or women can get counseling and have the test and scan for different amounts of money. But the sad part of this is that all this is happening across the road, where people can afford to buy the test, and I don't think it is fair on women not to have a test that is so accurate offered to them just because they can't pay for it. And I think the National Screening Unit does need to take this up and publicly fund it in a certain way. And I think that would also make sure that it is ethically used, that there are policies and guidelines in place, and that it is also regulated appropriately. I will leave you with that.